We'll be discussing the second part of chapter 11. Posterior mediastinal masses can either be due to neurogenic, vertebral, or vascular abnormalities or cyst formation. Neurogenic tumors are classified by their tissue of origin, either arising from intercostal nerves, sympathetic ganglia, and paraganglionic cells. Neuroblastoma and ganglioneuroma are most common in children, whereas schwannoma and neurofibroma affect adults more frequently. Neurofibroma is associated with neurofibromatosis type 1, while schwannoma with neurofibromatosis type 2. Radiographically, it appears as round or oval paravertebral soft tissue masses, and CT scan shows erosion to the adjacent vertebral body or rib. There can also be extension from the paravertebral space into the spinal canal via an enlarged intervertebral foramen, which is characteristic of a dumbbell neurofibroma. In addition to the occasional demonstration of both intra and extraspinal components, MR of neurofibromas showed typical high signal intensity on T2 and often enhances following gadolinium administration. This is a 34-year-old patient. MRI images show a thoracic dumbbell neurofibroma with extension to posterior mediastinum, which is isointense on T1 and hyperintense on T2. Note the interdural component that is located in the left lateral thecal sac at D3 level with a large extraforaminal component in the posterior mediastinum, which is traversing through a widened neural foramina. In this contrast-enhanced CT of a left upper paravertebral soft tissue mass, we can identify the yellow arrow, and on the HLT1 weighted fat sat post-contrast MR, it shows enhancement, and CT guided biopsy confirmed this as schwannoma. Tumors that arise from the sympathetic ganglia can range from the benign ganglioneuroma found in adolescents and young adults to the highly malignant neuroblastoma seen almost exclusively in children under the age of 5. These are elongated, vertically oriented paravertebral soft tissue masses with a broad area of contact with the posterior mediastinum. Large masses may erode vertebral bodies or ribs, and calcification is seen in up to 25% of cases. This is a PA radiograph of a 15-year-old female revealing an oval vertically oriented right-sided mediastinal mass, the arrows. Contrast-enhanced CT shows low attenuation posterior mediastinal mass with calcification. This was surgically proven to be ganglioneuroma. Next, this AP radiograph in a 10-month-old female shows a large right posterior mediastinal mass with a well-defined inferior margin. The mass effect is exerted on the trachea and the right main bronchus. CT confirms the findings of a right posterior mediastinal mass with soft tissue density, and note the internal calcifications. Next, we'll proceed to mediastinal paragangliomas. Most patients will have hypertension and biochemical evidence of catecholamine excess, and CT and angiography will demonstrate a hypervascular mass. In MR, paragangliomas show a characteristic salt and pepper appearance on T1 weighted images due to the presence of multiple curvilinear and punctate signal voids that correspond to high velocity flow in intralesional vessels. An incidental finding of a well-marginated mediastinal lesion beneath the left main bronchus is seen in this patient. Further characterization with CT demonstrates a circumscribed mass interposed between the left superior and inferior pulmonary veins. Posterior superiorly, it abuts the left main bronchus. Next, vertebral abnormalities. Here are the various vertebral abnormalities presenting as posterior mediastinal masses. It can either be from paraspinal hematoma from trauma, infections like in staph or tuberculosis, neoplasm, degenerative changes, and others. The aforementioned processes may produce a paraspinal mass by one of four mechanisms: expansion of vertebral body or posterior elements, such as in multiple myeloma and aneurysmal bone cyst, extraosseous extension of infection, tumor or marrow elements, such as in infectious spondylitis, metastatic disease, and extramedullary hematopoiesis, pathologic fracture and paraspinal hematoma formation, and protrusion of degenerative osteophytes. So, neoplastic processes are usually easily identified by expansion and destruction of vertebral bodies with sparing of intervertebral discs. Bronchogenic, breast, or renal carcinoma are the most common primary sites of thoracic spinal metastases. Infectious spondylitis is distinguished from neoplastic processes by the presence of a paravertebral mass centered at the point of maximal bone destruction. In patients with paravertebral abscess secondary to tuberculosis or bacterial infection, there is narrowing of the adjacent disc space and destruction of vertebral end plates. In degenerative disc disease, we can see inferolateral projecting osteophytes, which is commonly right sided. Extramedullary hematopoiesis is recognized by noting expansion of the medullary space and cyst formation within long bones, ribs, and vertebral bodies with associated lobulated paraspinal soft tissue masses. This is a 34-year-old male with Pott's disease. The PA chest radiograph shows widening of both paraspinal lines, the arrows, in the lower third of the mediastinum. Coronal CT image B shows collapse of the vertebral body, black arrow, and craniocaudal extent of the paravertebral abscess, white arrows, which caused the widening of the paraspinal lines on chest x-ray. Sagittal T2 weighted MRI image C shows increased signal intensity within the affected vertebral body and adjacent intervertebral discs, thick white arrows, and the paravertebral abscess, thin white arrows. The abscess shows typical subligamentous spread between the anterior and posterior longitudinal ligaments with posterior displacement and compression of the spinal cord, black arrow. The sagittal image also reveals gibbous deformity caused by the collapse of the anterior part of the vertebral body. This frontal chest radiograph, on the other hand, shows a subtle right mediastinal mass. Axial and coronal contrast enhanced CT shows disc space narrowing and vertebral end plate destruction with a paravertebral inflammatory mass, the arrows. Biopsy showed staphylococcal infection. For vascular abnormalities, we have thoracic aneurysm, double aortic arch, dilated azygos vein, dilated main pulmonary artery, and esophageal varices. These are discussed in a separate chapter. For cyst formation, we have lateral thoracic meningocele, which is an anomalous herniation of the spinal meninges through an intervertebral foramen. It is associated with neurofibromatosis. Chest radiograph typically reveal a round, well-defined paraspinal mass that is indistinguishable from a neurofibroma. MR demonstration of a herniated subarachnoid space is a diagnostic technique of choice, while conventional or CT myelography demonstrates filling of the meningocele with contrast. This is reserved for equivocal cases. Additional clues to the diagnosis include rib erosion, enlargement of the adjacent neural foramen, vertebral anomalies, and kyphoscoliosis. Foregut cysts include bronchogenic cysts and esophageal duplication cysts and ureteric cysts. 90% of all ureteric cysts occur in the posterior mediastinum, more commonly above the level of the carina. On chest x-ray, it appears as solitary, rounded, well-defined mediastinal opacities. On CT, these are homogeneous lesions of water attenuation with distinct borders. MRI, they have high signal intensity on T2, and they are usually low signal intensity on T1 because they contain CSF. As mentioned, the most common location of neuroenteric cysts is in the posterior mediastinum. CT findings include thin wall with communication with spinal canal, and it is associated with malformations including vertebral anomalies, bowel duplications, and mesenteric cysts. Let's proceed to diffuse mediastinal disease. First, acute mediastinitis. It is caused by bacterial infection following esophageal perforation or a complication of cardiothoracic or esophageal surgery. Perforation may be from penetrating chest trauma, esophageal carcinoma, foreign body or corrosive ingestion, perforation following prolonged vomiting, like in Boerhaave syndrome. It is characterized by severe retrosternal chest pain, fever, chills, dysphagia, and often accompanied by septic shock. Physical examination may reveal findings associated with pneumomediastinum, with subcutaneous emphysema in the neck and an apical systolic crunching sound on chest auscultation known as the Hanman sign. Radiographic findings are widening of the superior mediastinum and pleural effusion. When mediastinitis occurs in association with Boerhaave syndrome, pneumoperitoneum and left hydropneumothorax may also be seen. CT is the study of choice for the diagnosis. Findings include extraluminal gas, bulging of the mediastinal contours, and focal or diffuse soft tissue infiltration of mediastinal fat. Localized fluid collections suggest focal abscess formation. This is a frontal. These are images in a patient with upper esophageal perforation from a foreign body. The frontal chest radiograph shows a widened upper mediastinum with bilateral pleural effusions. Contrast enhanced axial and sagittal CT shows mixed fluid and soft tissue attenuation within the upper mediastinum surrounding the esophagus, representing bacterial mediastinitis. For chronic fibrosing mediastinitis, the hallmarks are chronic inflammatory changes and mediastinal fibrosis. The most common cause of this rare condition is histoplasma capsulatum. The superior vena cava is the most commonly affected structure, and the most serious and potentially fatal manifestation is obstruction of the central pulmonary veins, which produces pulmonary edema that may mimic severe mitral stenosis. The most common finding noted on chest radiographs is asymmetric lobulated widening of the upper mediastinum, most often on the right. CT is the modality of choice for the diagnosis and assessment. Enlarged lymph nodes with calcification are the most common finding. The PA radiograph shows calcifications in the right paratracheal region. Axial contrast-enhanced CT at the level of the aortic arch demonstrate calcified right paratracheal nodes, arrows in image B, with calcified thrombosis of the superior vena cava, the curved arrow in image C, and dilated right internal thoracic azygos and subcutaneous venous collaterals. Note the lobulated dilatation of the unenhanced left superior intercostal vein, arrowheads in C, along the aortic arch, representing additional mediastinal venous collaterals. Injury to the mediastinal vessels resulting from blunt or penetrating thoracic trauma is the most common cause of mediastinal hemorrhage. Spontaneous hemorrhage may develop in patients with coagulopathy or with aortic rupture from aneurysm or dissection. Most common symptom is retrosternal chest pain radiating towards the back. The main radiographic finding is a focal or diffuse widening of the mediastinum that obscures the normal mediastinal contours. Pleural or extrapleural effusion may also be seen. CT demonstrates abnormal soft tissue within the mediastinum that obliterates the normal interfaces between the mediastinal fat, the vessels, and the airways. Chest The chest radiograph in this patient demonstrates a widened mediastinum. Coronal CT aortogram demonstrates a traumatic pseudoaneurysm of the aortic arch, arrow, with extensive mediastinal hematoma, asterisks. Next, mediastinal lipoma. Predisposing conditions include obesity, Cushing disease, and corticosteroid therapy. Common finding on X-ray is smooth, symmetric widening of the superior mediastinum. However, if the amount of fat deposition is significantly increased, it may show lobulated margins. The trachea remains midline in position, in contrast to those with mediastinal tumor infiltration or mediastinal hemorrhage or narrowing. CT provides a definitive diagnosis by demonstrating abundant, homogeneous, unencapsulated fat that bulges the mediastinal contours. Heterogeneity within the fat may suggest other conditions such as neoplastic infiltration, infection, or hemorrhage. This frontal chest radiograph shows a widened mediastinum, and the axial contrast enhanced CT at the level of the aortic arch shows abundant mediastinal fat, accounting for the mediastinal widening on the chest radiograph. Malignant involvement of the mediastinum is typically seen as discrete masses or lymph node enlargement. Plain radiographs, however, are nonspecific, usually demonstrating mediastinal widening. And CT shows soft tissue infiltration of the normal mediastinal fat and obliteration of the normal tissue planes. Next, pneumomediastinum. Here are the various intrathoracic and extrathoracic causes of pneumomediastinum, including positive pressure ventilation, esophageal injuries, infections with fistula formation, surgeries, and others. Frontal and lateral chest radiographs in a patient with acute asthma exacerbation shows perihilar bronchial coughing, arrow, and pneumomediastinum extending into the neck, producing subcutaneous emphysema. Also note the continuous diaphragm sign, the arrowheads, and in the coronal CT scans at the level of the ascending aorta, it shows airways thickening and confirms pneumomediastinum extending into the neck. Next, we'll discuss unilateral and bilateral hilar enlargement. This is a table from Brandt showing different causes of unilateral hilar enlargement. Um, it can be from lymphadenopathy, either from malignancy or infection, vascular, from pulmonary artery dilatation, or cyst in origin. A hilar mass usually represents bronchogenic carcinoma or confluent lymph node metastasis. Malignant melanoma is the extrathoracic neoplasm with the highest incidence of intrathoracic nodal metastasis. This frontal chest radiograph shows an enlarged right hilum, and contrast enhanced CT through the right hilum shows an enlarged lymph node, enlarged right hilar lymph node, and biopsy of this mass revealed non-small cell carcinoma. In another patient with ovarian carcinoma, we can see a left hilar mass, and the CT shows an enlarged left hilar lymph node reflecting metastatic disease. Unilateral hilar or mediastinal lymph node enlargement is a characteristic feature in primary pulmonary tuberculosis in children, as well as in fungal infections such as histoplasmosis and coccidioidomycosis, bacterial infections including plague, tularemia, and anaerobic lung abscess, and viral infections such as in mono and measles pneumonia. Abnormal enlargement of the right or left pulmonary artery can either be idiopathic or from valvular pulmonic stenosis, pulmonary artery aneurysm, or pulmonary artery thromboembolism. This scout view from chest CT shows abnormal convexity in the region of the main pulmonary artery, and enhanced CT shows dilated main pulmonary artery with normal right and left pulmonary arteries. In this patient with valvular pulmonic stenosis, in the radiograph, we can appreciate a middle mediastinal mass with left hilar enlargement. Axial conscious enhanced CT shows main and left pulmonary artery dilatation as a result of the valvular pulmonic stenosis. Bilateral hilar enlargement is the result of enlargement of hilar lymph nodes or the central pulmonary arteries. Presented in this table are the different etiologies. Can be from malignancies, infections, granulomatous infections such as sarcoidosis, and pulmonary artery dilatation. This is a PA radiograph in a patient with sarcoidosis, revealing bilateral hilar lymph node enlargement with upper and mid-lung reticulonodular opacities. The conscious enhanced CT at the level of the carina shows bilateral hilar lymph node enlargement. This frontal chest radiograph shows central pulmonary arterial dilatation with attenuation of the peripheral vasculature known as pruning in a patient with severe pulmonary arterial hypertension due to COPD. So for the last part of my report, we'll discuss small hila. Small hilum or hila can be unilateral or bilateral. Unilateral causes can be congenital, like absence or hypoplasia of the pulmonary artery, pulmonary agenesis, aplasia, hypoplasia, scimitar syndrome. It can also be acquired, such as in Swyer-James syndrome, lobar atelectasis, or lobar resection. And bilateral small hila can be seen in emphysema, decreased pulmonary blood flow, like in fibrosing mediastinitis, tetralogy of Fallot, valvular pulmonic stenosis, and Epstein anomaly. In any patient in whom a small hilum is a new radiographic finding, a CT scan should be performed to assess the mediastinum for central obstructing lesions. That is the end of my report. These are my other references. And
Thank you so much. Oh, for the question. Thank you so
yes,
much. Okay.
which sympathetic ganglia tumor is more common in children under 5 years of age? The answer is neuroblastoma. Which mediastinal mass in which the trachea remains in midline? Answer is mediastinal lipoma. Which is correct regarding intercostal nerve sheath tumors? Both are correct. Thank you.
Thank you so much, guys, for your extensive report on posterior mediastinum, mediastinal structures, and hilar structures. Now, I would just like to reiterate to our dear trainees, both residents and fellows, that whenever, of course, X-ray is the first modality of choice that we encounter, and whenever we see density located at the posterior mediastinum, the first thing that we should think of are the differentials for the spine and the nervous system, because 95% of them are originating in this anatomic location. Only 5% are the other differentials comprising the lymph nodes, the foregut duplication cyst involving the adipose tissues. Majority of them originates from the spine and the nervous system. So what do we do next? We advise the clinician to do MRI, because MRI is the modality of choice to differentiate these individual neurogenic tumors. Now, after identifying those neurogenic tumors, we divide them into either benign or malignant. CT would come in. What's the purpose of doing CT? To do a surveillance if there are metastases, if there are primarily for metastasis. In our institution, most of these posterior mediastinal masses, especially if they have imaging manifestations of malignancy, they proceed to PET. We have the facility for that. So don't be surprised if there are clinicians who would ask us, would PET be helpful at this time? Yes, PET would be helpful. So that is the thought process that I would like you to have whenever we encounter posterior mediastinal masses. Now, on the next part of the report of Zeiss, she mentioned about differentials on mediastinal masses, hilar masses. Chest CT with contrast would suffice because, again, morphology, anatomy can be definitely defined on chest CT with contrast. And when there are mediastinal masses, I would like to mention a special mention. Our interventional radiology consultants are right here this morning. So we have them come on board and we ask them how to approach mediastinal masses for biopsies. So we also to them and learn to them on what and how is the best approach to biopsy or take sample whenever there are mediastinal or hilar masses that we encounter. Um, Thank you so much for this is the part where the floor is open for questions and for comments from our audience. Further questions po? If there are no questions, comments, thank you so much for attending this morning's FDR. Thank you so much for all the consultants for giving their time in this morning's activity. Have a good day, everyone.